Spritztube is a supraglottic and infraglottic airway device. It features with two separate cuffs, an esophageal cuff and a supraglottic cuff, which can also go into the trachea. Here you can see it assembled and ready to use with its dedicated metal stylet covered in silicone and non-traumatic. Both the Spritztube and the stylet can be re-sterilized up to 30 times. It has a beveled tip that allows easier sliding when the device is used for intubation. The main idea behind the device was to allow anesthesiologists or emergency paramedic staff to achieve supraglottic ventilation in a quick and efficient manner. It is introduced by retromolar way. If necessary, you can slightly pull the patient's jaw. Basically, it can be inserted blindly till the depth marker present on the tube. At this point, you can already feel the pressure increasing in the distal cuff placed in the esophagus. The stylet is removed. The supraglottic cuff is filled with 60 milliliters of air, causing the tube to retreat naturally to the optimal level for the patient, with the proximal cuff situated between the choane and larynx opening. In this way, an easy and rapid supraglottic ventilation is ensured. At this point, the patient is well ventilated and oxygenated adequately, and Spritztube can allow to proceed with intubation, if necessary, with any available method of preference. Keep watching for further details. Now we will intubate the patient with video laryngoscope. We disconnect the ventilation circuit, deflate the supraglottic cuff to allow the blade introduction into the mouth. Insert the blade, make sure to see the glottis. At this point, insert the video laryngoscope dedicated stylet into the Spritztube lumen and proceed with intubation by pushing the tube into the trachea under video guidance. Here we see the vocal cord and the tube on the monitor. Now that we have the tube into the trachea, remove the blade, remove the stylet, and inflate the proximal cuff to the right pressure. The Spritztube has now become an endotracheal tube. Check the ventilation efficiency. If the case requires it, for example, the intubation is expected to be prolonged, or the surgery will require the stomach evacuation, the esophageal cuff can be deflated and easily removed by pulling it out from the esophagus. To avoid contamination, wrap it with the glove and leave it outside the patient. Now the patient can be ventilated again. So, we have just performed an orotracheal intubation. The patient is under supraglottic ventilation. For the following procedure, we disconnect the patient from the ventilator and deflate the proximal cuff. At this point, the apnea phase begins, but it will last only for a few seconds, necessary for the next moves. Introduce the rigid fibroscope through the Spritztube lumen and push it inside past the tube's tip. Then look for the arytenoids. Adjust the instrument screen if needed. When you find the vocal cords, simply push the Spritztube past the vocal cords, using the rigid fibroscope as a guide. Then remove the instrument. That's it. We can now reinflate the cuff that has become tracheal and resume the ventilation. Questa volta è diventato tracheale e si va a The patient is ventilated supraglottically, and we can decide to intubate him in a safe manner without losing the airway and without stopping ventilation by intubating with a flexible fibroscope using the T-mount. Basically, we will perform a fibroscopy in a ventilated patient. We take our fibroscope and introduce it through the T-mount. The ventilation is not interrupted. The fibroscope is advanced along the Spritztube lumen and past its tip. Once out, we can actually see the esophageal cuff. So, if we are too deep, we pull slightly back the tube and the fibroscope. Find the arytenoids, the glottis, the vocal cords, and push the fibroscope to the carina. Our patient is still ventilated here, but at this point we deflate the supraglottic cuff briefly, just to allow to push the tube into the trachea, using the fibroscope as a guide. We pull back the fibroscope above the trachea and check the tube's correct positioning. Then we simply re-inflate the cuff and remove the fibroscope completely. So we have just performed an easy intubation in a patient that could be a case of difficult airway or a patient arriving in emergency. We use a flexible fibroscope, which is a gold standard for difficult airway management in a ventilated patient.